Shall make a start. Welcome to the Health and Wellbeing Overview Scrutiny Committee. This is on the 2nd of September. Welcome to new members that couldn't attend our inaugural meeting. First item on the agenda is any apologies? Full house, excellent, well done. Minutes of the meeting that was held on the 22nd of July that have been circulated. Can I have a proposer that they are true record? Councillor Hunter, thank you very much. And a seconder? Thank you. Councillor Smith. Disclosure of members' interests. Unusual in this committee to have any interest, but has anyone got anything that they need to declare? No. First substantive item is the overview of the NHS, which is a big topic if ever there was one. How long have we got? This is really useful presentation because, what we predominantly look at is obviously the NHS, and we have colleagues who are going to give an overview of the service, which will inform, we'll have some questions to ask after your report, and it will be useful information moving forward on this committee and otherwise. So, over to you.
Thank you very much for the invitation to come and talk to you today. My name is Rachel Mitchison. I am Director of Delivery and I work for the Integrated Care Board, and I cover the remit of Northumberland and North Tyneside, and hopefully in this presentation I'll also be able to help you understand what that organisation does and sort of what I do within that. So thank you. Really nice invitation, actually, and I have quite enjoyed putting this together. I do feel enormously proud to work for the NHS. It's been around for a long time. It consistently changes, but it's quite an interesting time to be doing a presentation. What I did at the start was just have a look back, actually. So I'm just going to touch on when the NHS started, which was a long time ago in 1948, which you probably are aware of. I'm then going to try and describe what we call providers, and I will try and help you understand the language, but I thought it was important to use the language so you could get used to it. And I'll describe what we do in primary care, secondary care, and tertiary specialist care. And then I'll go on to talk about the sort of policy commissioning, which is more what I'm involved with in the Integrated Care Board, but what our national and regional colleagues do. And we've just received a 10-year plan, so I felt remiss of me not to just mention that as well, although there could be a whole presentation on that, which I'd be very happy to come back if you're interested. And then I've just got a few reflections, very happy to take questions, and I am staying till the very end of the meeting, so if people wanted to catch me at the end as well, equally happy to do that. So when it all began, a long time ago, interesting to look back. So the principle of the NHS, very much free care based on need and not on the ability to pay, was really quite something when that came about. And this whole ethos that it is really from the start to the end, the cradle to grave, it is still very much part of what we provide today within the NHS. What I found quite interesting when I looked back was there was this concept of it was the first time the government took responsibility for people's health by bringing in the NHS. And actually that was quite controversial at the time, and others felt that people should take responsibility for their own health. And I just think that's quite interesting. Hopefully when we come to the end, when we think about even what Jill's going to talk about prevention and how much we can take some responsibility for our own health, but that was why the NHS was set up. I also liked this little diagram. It was quite simple. I've never seen a simple diagram like that for a while. I think our diagrams now are quite complicated, but very much that family doctor, GP, the centre of the NHS and that sort of access point to other services. But interesting headlines: state takes over. Private private doctors will still be there, but doctors directed. It's just quite interesting about this was quite a positive thing, yet there was obviously some scepticism in the system, which we probably have as well today. So just a few reflections. So this is the infrastructure we have today in a sort of simplified version of a triangle, and I'm going to start at the bottom with our providers, and our place-based partnerships are really a very crucial to that. So what I mean by providers are primary care, GPs, community services, all our hospitals, the voluntary community sector, and how they all kind of work together. And I'll tell you who we've got available for us in Northumberland. I'll then talk about the Integrated Care Board, which is more about the commissioning and the buying of healthcare and the contracts, and then the sort of national policy. So to start with, I'm going to start with our general practice in Northumberland. I've just got a map of Northumberland there, and all those lovely coloured dots represent our GP practices across the patch. So we have 36 general practices in Northumberland. And we have very good primary care, and what I've done is colour those into groups, because what we now have very much encouraged our GPs to do is to come together into groups, and they then have a contract, and they work together to achieve that contract. And that grouping is called primary care networks, or PCNs, because we like to abbreviate everything. So these, when this came about, we very much asked the practices, who would you like to work with, who are you comfortable to link up with? And you can see from the colours that there is a sort of geographical spread there. Certainly the two little red ones in Blythe and the ones around Ashington sort of based together in a geography. Broadly the north are together, although you can see there's a couple in Morpeth that have joined that network. And the idea is that they would get to know their population and work together to provide some additional contracted activity above their sort of core general practice. And there's some really good examples of that working well with things like care homes, where they kind of manage a group of care homes together, which helps the care homes build up a better relationship with primary care, good planning for the older people. So there's a few, they're not an organisation as such, but they do have a shared contract of how they work together. But general practice, of course, is not just about doctors, and as our needs get greater, we can actually benefit massively from other professionals. And so often we try not to talk about general practice, but about primary care. And within primary care now, there are nurses who can manage some long-term conditions, obviously do a lot of immunisations around for families. There's access to physiotherapy in practices, mental health practitioners, pharmacists looking at reviewing people's prescriptions, and making sure that they're on the right ones, and even things like social prescribing. And so looking at the wider voluntary community sector, what are the other areas that can help and support people? So it is much broader now, which is why I think we try and use the term primary care, because it's a number of resources and not just think about doctors. The other areas that we look at in primary care are pharmacies, and again they have policies around Think Pharmacy First, so trying to get people to use pharmacies. You can get an appointment with a pharmacist to talk to them and get some advice and expertise, and they do offer various different services, one of which is you can get your flu jabs and things now done in the pharmacy. But actually, again, the services that you can get has grown and is broader. Optometry, again, for eye care is part of that primary health care. It's quite amazing what an optician can find out about your health, actually, and plug you back into different referral routes and make sure that you get those things looked at, as well as obviously for children to make sure that they can see and access the curriculum. So really a key part of those primary care services. Dentistry, I think you might have a more focused session on dentistry, and I'm certainly not an expert, but as an ICB and are recently involved in commissioning of dentistry, we have just published our oral health and dental strategy, which the committee might be interested in having a closer look at, just looking at fairer access, preventing dental disease, and making it easier to get care from an NHS dentist, which I think has been quite difficult in certain areas in Northumberland recently. All of these areas are controlled or get their work from nationally set contracts. So sometimes it is quite a challenge locally to work with that, because it is very much set from a national basis, and then we try and work with them as best we can to meet the needs of our population. And there are many discussions, I'm sure, nationally about how to resolve some of those challenges. So that's primary care. Moving on to what we would categorise secondary care, and Northumbria Healthcare NHS Trust is our hospital provider within Northumberland, and they also cover the population of North Tyneside too. So they look after, I suppose, the population about 500,000. There's just a list there of the services that they provide that you would probably expect a hospital to provide. They are quite different in how they provide their emergency care, and that top picture is a picture of Northumbria's Specialist Emergency Care Hospital, which we usually call NSEC, if you've heard that abbreviation, and that is quite different from other models of care, where all the sort of blue lights and emergencies go to one place to have that emergency treatment, and then they use the other two sites there, the Wansbeck with that sort of yellow at the front, and then Hexham General for more planned surgery, so people that had a planned operation, and actually that is a purposeful model, so that the emergencies don't bump somebody that's come in for planned surgery from a point of view of how they manage their theatres. So I think that's one of the reasons for that. As well as emergencies require so much specialist treatment from different doctors, and so having them all at NSEC enables them to provide a really good consultant cover from all the different specialities in one place. So some of it is around how they clinically have their model. And then along the bottom are the community hospitals. Obviously, we have a very big county. It's really important that we enable and try and provide care as close to people's homes as possible. In the far there's the Clock Tower of Berwick, which is about to be, well, it's all built, isn't it? Lovely new hospital. So we'll need a new picture there soon for when that's opened. So that's really exciting for Berwick. There's a hospital in Alnwick, community hospital in Alnwick, one in Haltwhistle, one in Rothbury, and one in Blythe. And predominantly, that some of those have GP practices with them, some outpatient activities, and a ward more for sort of frail elderly, older people, rehabilitation. So really helpful for people to get back to those sites maybe prior to going home, so they're a bit closer to home for families to visit. So that is sort of a whistle stop of Northumbria. I've included Newcastle hospitals as well, because this is what we would consider sort of specialist healthcare or tertiary care. They provide everything that Northumbria provide, but they have additional specialisms as well, mainly around sort of neurological conditions, neurosurgery. They do the specialist children's care and have a whole range of very skilled paediatricians, the transplants, cancer care, genetic disorders. They're classed as a teaching hospital. They're very closely aligned with the universities, so they do a lot of research and that type of thing as well. So lots of training of doctors and professionals there. So they of course have the Royal Victoria Infirmary, the RVI, they have the Freeman, and just pictured there the Great North Children's Hospital as well, because they obviously provide a lot of very specialist children's care. So moving on, we also have hospitals that manage mental health. So those two really look after our physical health. And then we have CNTW, which is Cumbria, Northumberland, Tyne and Wear. And they provide a wide range of services for mental health, learning disabilities, autism, neuro rehabilitation as well. And I just put a little map on there, and obviously you can have the slides afterwards, which has just got a bit of detail, but just to show that they don't just work in Northumberland, they work across Cumbria, Northumberland, Tyne and Wear, Newcastle and Sunderland, so they have a slightly bigger footprint. However, they do work very locally, and they are divided up to enable us to work locally. So certainly we would work with very similar people who have a remit for sort of Northumberland, and they divide themselves up into looking after people in the community and community care, their inpatients, and then they have some quite specialist services with regard to neurorehabilitation, children's services and secure care services as well. So that's how they kind of configure. Very much work in partnership across social care, voluntary sector, in what we have been trying to do around transforming community services, and that is about trying to manage people closer to home, looking at, we've managed to commission services like the Safe Haven in Ashington, which is called the Bothy, where people can go and access voluntary sector, the recovery college training to generally recover from mental health conditions and get back into some other activities. So that's a little flavour of how we kind of work with the Mental Health Trust. And then we've got NEAS, or the North East Ambulance Service, and they cover, again, I've just put a map in just to show the size of the patch that they cover really across the North East. As an integrated care board, we have Cumbria, but NEAS don't cover Cumbria. That's a different a service from the Northwest. So they obviously manage and run their ambulances, and a key part of that is the 999 control centre and how they triage all of those calls that come in and categorise them on a 1 to 4 basis, depending on the urgency and then depending on the timing that they decide is required to recover that person, look after them and take them to the right destination. As well as the 999 calls, they also have a triage service for the 111 calls. So these are medical advice when it's a non-threatening emergency, and you can access that out of hours, and they will help to navigate you to the right service, whether that is another urgent treatment centre, back to your GP, a pharmacy, depending on what the need is. And so that's a very, very quick tour of what the ambulance service is. I think the other thing to note, having recently seen the back of an ambulance, just how much technology is in the back of those ambulances. They are like mobile intensive care units, really. So you know, they really can provide some real very intensive care for those really critically ill patients, which is what we kind of need. But it is quite incredible how technical that has now become, really, and how much kit is in the back of an ambulance. Really, it's quite impressive. So that's the Ambulance Trust. So that's hopefully a bit of a whistle-stop tour of all the providers. My next bit is to just talk about the Integrated Care Board and I guess the importance of the commissioning and what our role is around more looking a bit like a helicopter across all of those providers and making sure that we are improving the health needs of that population, and that all of those providers are doing the right thing, and that the money is flowing to the right places. So Integrated Care Board's very new, really, as an organisation, came into being in July 2022. They replaced clinical commissioning groups, if people recall them. They were quite small organisations, whereas this is obviously really big, covering the whole of the North East and North Cumbria. And what an ICB tends to do is plan, buy and oversee health services for people, and as well as making sure things are working well and improving the sort of quality and the safety. The other aspect of ICBs is around trying to join up that health and care, making sure that we don't duplicate and that we work together to try and improve health for local people, and looking to reduce those health inequalities, which is obviously really important, making sure our services are accessible from that point of view. When the ICBs came about, they very quickly took some additional responsibility for what they already commissioned. So we have commissioned primary care services for quite a long time as clinical commissioning groups, and the commissioning of pharmacy, optometry and dental sat with regional colleagues, but they were delegated to us in April 23, and we now have those responsibilities as well. So I think we are just still getting used to that and learning about that. We also took over things like emergency response and care coordination. So we have regular calls with all of the trusts across the patch, particularly in times where there's surge, and make sure that they are working together. If one is particularly busy or stretched, can we then divert the ambulances to somewhere else? So we do some sort of overseeing of that system, particularly in times of surge, and have taken on the responsibility, should there be an emergency, to be the sort of health responder. We did also have to reduce our running costs in January 2023, so there was a reduction then of 30% to come in line with the cost envelope we were given to run the organisation. And we are also currently going through a further restructure, reducing by another 33%, which has come in line with a document that came out on the 1st of May, which was like a blueprint, really refocusing what it is we should be doing and moving into the role of being more of a strategic commissioner, and therefore working a little bit more removed from our providers, being a bit higher level really, in how we strategically commission rather than getting too involved with our providers, allowing them to work together and do that bit themselves. So still going through quite a bit of change. This is just a slide to just explain really what the core functions of an ICB would be, from a point of view of trying to be that sort of system leader and improve population health. So really important that we understand what the local context is, understand the population's needs, develop plans and strategies for how we're going to tackle those needs, deliver the strategy through paying. I suppose our main function is pay those contracts, make sure that people have the right resource allocations to deliver what we want them to deliver, and then obviously evaluate the impact of that, and then you kind of keep going back around that cycle, because there's always things that you can do better and improve. As I said, we are going through a restructure, so this has been approved by the board. I should have changed that at the top there, but it is subject to a consultation that we will ultimately take our staff through. And so we will move into these sort of groups, having a sort of insight, strategy and policy team, a commissioning group as you'd expect, and that sort of corporate services. So just give a flavour of how we're potentially looking to change going forward. So that gets us to the top of the triangle, you'd be pleased to know, and this is looking at how we get our sort of national policy and strategy set. So we received just earlier in the summer our 10-year plan, and you might have heard some of this already. This is just a bit of a very, very short summary of 3 key shifts that have been well publicised in the media and are very much from this plan. So big focus on moving from hospital to community, so transforming healthcare, looking at easier access, GP appointments, a big focus on neighbourhood health. There's a lot of talk about neighbourhood health centres, but actually how do we work as better teams to look after people in neighbourhoods, better dental care, quicker specialist referrals, round-the-clock mental health support, but very much all designed around providing care closer to home is a big driver in the plan. Big transformation around the analogue to digital, creating that seamless healthcare experience, digital innovation, looking at patient records, lots about patients being able to self-refer and use of an NHS app, and really looking to bring all of that up to date. And then a really crucial one, really thinking about how we move from sickness to prevention, and how can we shift our thinking to preventable healthcare and making more healthy choices easier. They are talking about things like energy drinks for under 16s, looking at weight loss services, home screening kits, lots of things that could help us move in that direction. Did I miss the slide there? So this is just a little bit more information on that, which I won't go through particularly. I want to leave some time for questions, but in looking at the slides, that might just help you realise some of the things that they're sort of looking at doing in those sort of three categories, and just gives a bit more detail and a bit more of a flavour that you might want to refer back to later. And obviously we have got a while to work to deliver these. So today, the NHS 77 years on, we probably look a bit more like that. There's probably more complicated drawings, aren't there, about how it all comes together. I also found some pictures, and I just thought it's quite interesting how much we've changed from these really long wards, people very close together. I love the fact that one of those beds is on bricks on the nearest to the screen. I just think, my goodness, I think that's quite safe from a health and safety point of view, is it? And then modern, much smaller, a lot of technology in the room, beds that go up and down, back and forward, sit you up, quite incredible. Operating theatres, I mean, wow, look at the technology we've got in operating theatres, to that very shiny silver, little bit of oxygen in the corner. I mean, just... It does, exactly, it does actually, yeah. That bed looks very narrow, doesn't it? But yeah, interesting. And I guess I mentioned before, just thinking about ambulances, that the ambulances in the past literally just picked people up and took them places, and now actually you can start your treatment right from the minute that you get in the back of the ambulance. So huge transformation and huge change, and it just doesn't stop, does it? So reflections, I think the principles probably of the NHS remain the same, but I think that prevention focus is really critical, and can we do more ourselves to stay healthy, and as an NHS can we try and change our focus from just looking at illness to try and have a more of a health focus, which I'm sure leads in very well to Jill. We are also, I think, for the first time in healthcare, looking at more of those wider determinants, housing and employment. We've worked very much with the council to do that. There's a lot to still learn about that, but how those all play into being healthier. And we are just at the minute launching a new pathway to help primary care if people are off sick in work but off sick, try and get them fit and healthy and back to work quickly. Again, working with the council around a pathway into providing people with work coaches and support, which is all really positive and nice to be part of. Partnerships, collaboration, absolutely critical to the delivery of that 10-year plan and to health and that relationship between health and care, absolutely crucial. Neil is here. I know he presented last time, but we have a really good partnership about how we manage our vulnerable adults together. The council's responsible for that, as are we. The same group of people working together makes it much easier. So if that's things like continuing healthcare, we'll have a really good arrangement in place. Vaccinations, again, very much part of our winter plan, almost higher on our winter plan than what we would normally think about for a winter, but really, really makes sense, doesn't it? And obviously working with public health and making sure we've got the right data and we're reaching the right people. And neighbourhood health will be totally key going forward. We need to understand our populations, patient flow through hospital, etc. Always up for sharing and learning. There's always more we can do. And engagement and working closely with our communities. And, although that's at the bottom, this is not particularly in any order, but really do value the role and input of counsellors. I know that Georgina's really active. I have some emails from her, but actually that information is really helpful. It makes me think, and actually people are coming to you with concerns. I would like to know about them so that I can work it through. It might be something I can help explain, or actually it might be something that we can do something about to try and move. So, really great to be here and happy to be a point of contact should you have people coming to you, because I would like to know. Thank you very much. Any questions?
Thank you. You preempted me because I was just going to say how helpful you are, and I didn't want to sort of increase your email inbox, but I thought it would be useful, particularly with new councillors, to say that you are available to receive feedback and specific concerns you have. You will get that in your casework. Does anyone have any questions? Councillor Green, isn't it?
Yes.
Thank you.
Hi, thank you. I'd just like to know why dentists seem to be an enigma amongst themselves, that a lot more go in private, and why are fees charged?
Right, so I'm not an expert on dentistry, but and actually the fees have been in place quite soon after the NHS started, I think. But so I can't really answer those questions honestly, but I do believe one of our ICB commissioners is going to come and talk to you, so they'll be able to answer all of those questions. It is a very old contract, it's nationally set, and that's something we can't do a lot about, although we can obviously link in and try and influence that. I think it probably does need to be brought up to date, and my understanding is that, you know, sometimes dentists find it very difficult to work within the remit of that contract, and therefore it's almost easier for them to go private. And we have tried to work really hard with them to understand that and commission more locally, so that we can incentivise them in a different way to meet the needs of our population. And that in itself is why we've done that strategy, which is really important, so that we can have that better understanding and try and work to that. But it's going to take some time to recover from that, I think. And it's difficult once the dentist makes the decision. It's their decision to do it, so we don't have a lot of levers to stop them doing that. But I do think having a dedicated slot with the detail would probably be beneficial.
I don't want to use a pun, but try to get answers out of them is like building teeth. But they are it is on the work programme to get an update on what's happening in dentistry services. I saw Councillor Hunter next. Yeah.
Thank you, Chair. That was one of the, I was going to ask for that to be on the work programme, and I think again if we could have the 10-year plan to come on the work programme. On the ICB, with the funding you get, is it able to be moved about if you find that there's a better use for the funds as the budgets? If you could, is that possible to move that about, or are they set as to that budget must be used for X and Y? And my other question is, how are we doing about trying to increase the uptake of children's vaccinations? Because it seems to have hit the headlines again about whooping cough and etc. Because it's not just the children that's affected, it can be other members if they pick up the infection and pass on. That's my two questions, please.
Lovely, thank you. So it's complicated, isn't it? So some budgets there's flexibility, some budgets there aren't. So we still follow predominantly our population attracts the money, and then there is some flexibility about how we spend that in the population. But then things like dentistry will have their own pot of money for the whole of the North East North Cumbria of how it's spent. So some flexibility, some not is the honest answer to that. Very good point around children's vaccination. I was in a discussion this week about that, and we do have a local meeting, and we have access to that data, and there are plans in place to improve that. I mean, Jill might want to say more on the vaccination front, but we are aware that there is a problem, and there is quite a campaign to try and encourage more children, more families, everybody to have vaccinations, really.
Just to, thank you. Just to add to that, and we can bring more detail in. Again, it might be something that you're interested in, bringing the immunisations team into scrutiny. But as an assurance message in Northumberland, our provider has worked incredibly hard, and we've got outstanding uptake for our MMR. We are leading in the North East in relation to that, and we've got a campaign just about to launch for the winter flu season, where we do want to see our children come forward for that, because we know that whilst flu is not a good thing for our children, it's actually because they're a main transmitter into our vulnerable population, which is why we do need to increase the uptake, and we're working with the likes of our settings, our nurseries, to be able to look at how our parents can find it as accessible as possible in their day-to-day lives to be able to encourage their children to come and be vaccinated. So we've got a big comms campaign, as Rachel says, and we're very minded to look at how we can target and nuance that campaign, because there's certain cohorts of the population who are less likely to come forward than others, and we need to adapt our communication to encourage people who perhaps aren't as forward-thinking in relation to vaccinations.
Councillor, do you think that would be useful to have on the work programme? I know we've got a separate item, yeah? Councillor?
Yes, I think that would be very helpful, Chair.
Yeah? Yeah? You've noted that down, that's good. The next person I saw was Councillor Oakley.
Thanks, Chair. I just want to know, how is it decided how much GP time a specific area might get? So in Pegswood, for example, we have half a day a week to see a doctor. Otherwise, we've got to travel into Morbus, and I was just wondering how that's worked out. Thank you.
I mean, that is for the practice, I guess, to work out how they organise themselves. And so I think branches are part of how that practice would work. So they would, it's how much resource they've got, how they best deploy it. It would be their decision, really, nothing that we would do. It would be entirely up to them. So, I mean, I would, if you've got concerns, I would go and speak to the practice and have that conversation with them. I know sometimes if they can't just put a doctor on their own, they might need other members of staff, and it's just how they make sure that the staff are all fully busy while they're there. It can be a sort of juggle for them, but I would speak to them if...
I have contacted them about 3 times now.
Oh, have you? Okay,
yeah.
okay.
Thank you. Thanks.
Well, I'm happy to help if I can. If there's a particular concern, I could speak to my primary care lead about that, if that was helpful. Yeah, no problem.
Councillor Carr.
Thank you, Chair. And a very good presentation. It's always good to see some pictures thrown in there. Interested to know about the AI. How is that going to enhance? And what will that look like locally in Northumberland? And are there any data as to when that's going to be rolled out, or if it is already being rolled out at the moment?
Isn't AI interesting? I mean, I think we're all on a learning curve, aren't we, around that? So I think that some of how we're using it is just probably how you're using it, looking at, can it summarise your emails, can it summarise minutes of meetings, you know, and actually it's amazing, isn't it, some of that. So I think we are looking at certainly things like administration and how can that be improved. I think it's still really early days, isn't it? We have a digital team and digital strategy that we are trying to look at doing ourselves as an ICB as we reduce our running cost. How can we make sure that we use people's time more effectively? How we're going to use it entirely in the NHS, I'm not entirely sure yet. I think there's, you know, nervousness, isn't there, about it, but we might see it grow as we get more and more familiar and used to it. But I think we all probably need a bit of training on it and a bit of time to kind of see what it does. I think equally we have to be wary, don't we? I know that a couple of times I've asked it for some examples, and I thought that doesn't seem right. And then when I've checked, is this a real example? It has actually told me it's made it up, which I'm glad I checked. But so I think there's some caution, isn't there, behind it. But we're certainly using it a lot for minutes of meetings and that sort of thing, basic level.
Yeah. It does have those benefits, Chair, to enhance work and productivity, but in terms of, you know, national health benefit, I'd be very interested to see how it's going to develop going forward. So, yeah, thank you for that.
Okay.
Thank you, Chair.
Thanks for raising that, because I think across the piece, not just in health, when
massive.
we're probably not talking about AI enough, because it is
Yeah,
just so unbelievably transformational. So
very
thanks
clever.
for raising that. Councillor Chicken.
Thank you. Great presentation, so thank you very much, and thank you for being here. As our key partners in health, it is so important that we have a good relationship with the NHS. It is, from our side of things, it crosses over so many times in anything that we are trying to do, our key services, our key performances. We always like to prevent where we can, which is why we have so many of those services in there, to make sure that we can prevent as many people as possible from having to use that NHS and taking control of their own health, their own lives, which is what people want to do. They want to be self-sufficient and they want that autonomy. And again, having that key relationship with you is absolutely spot on. As I say, by your presentation, the amount of services that we have, the amount of bodies that we consult with, that is the key, is getting it really from the shop floor, shall we say, And these meetings like this is a key area where we can voice our opinions, ask our questions. For example, Councillor Oakley there, who did not get an answer where she needed it, she can come here, she can get an answer as to where to go. And there will be a lot of people in our communities who feel like that. They will come to us as councillors as their first port of call of where on earth do I go? And we can raise that with you. Just to add on a little bit after Jill O'Neill there, we're always tackling to get, you know, children's uptake, adults' uptake of vaccinations as much as we possibly can. And one of the key things that we've come up with this time around is to actually implement the vaccines for influenza for small children, which is, it's just a nasal spray, it's not an actual injection, it's a very mild form. But whereas beforehand they used to have to try and book a GP appointment to get their child to have that, and if anybody has ever had to deal with a GP recently, that ain't happening very quickly. And once you hit that barrier, that stops a lot of people from actually taking that up. They've tried, they haven't succeeded, so oh, I can't be bothered with it anyway. Or because they have such busy lives, they just forget to take it back up again, and that can have some serious consequences. So bringing that into nurseries that are attached to our schools, we're already there, we're already sort of doing the vaccinations as the older children. Bringing that in to the nursery school children kills two birds with one stone. And it means parents don't have to worry. And for any busy parent, that's a real key element to any sort of care for their child, is just not having to worry. That's another thing ticked off the list. But we're always working on more ways and more things. So if anybody does have any suggestions as to what they think we ought to be looking at, or we could explore, we're all ears. We would love to hear it. So thank you.
Thank you. Councillor Jones.
Thank you. I probably should have just said this earlier, but GP, we had this committee about a year ago went into great detail on GP appointments and how they were working. Particularly, there was a lot of concern about the practices that do the ring at 8 o'clock in the morning. A little while ago, there was quite a lot of press announcements that the government has said this was going to stop. But it doesn't appear to have stopped, certainly not at the practice I use, where you literally have to ring every day to try and get an appointment. Do you know what's happening about that?
Good question. So I think we obviously are trying very hard to work with practices. So I know that you did have a deep dive on access, and it is quite complex, isn't it, now? Because actually you don't always need to see a doctor. It's about triage and seeing those other professionals. But I know that our GPs meet together as a collaborative, and I know that it's on their work plan to kind of have a look at how they manage their access. And we do have a number of different models. So hopefully it will ultimately it will change. I think people, the GPs are very aware that is a pinch point. It's just how they manage their demand, and it just takes a bit of time for them to look at alternatives and move away from that. So I know it's very much on their plan, and one that I'll definitely follow up on and see where they're coming from. But quite a number of practices have moved away from that now, so hopefully it'll continue to grow.
Thank you. It still doesn't help the families. If you have to ring at 8 o'clock in the morning, it's getting ready for school time. You know, how families manage, you just cannot sit on the phone that length of time.
And it follows your point that Councillor Oakley made as well. There's a bit of an issue about accountability of GP practices, because some are a lot better than others. And there's one, in my, obviously I won't name them, but wide area, who been in touch with about how difficult it is to get appointments. And then the practice manager sent me a grumpy email saying, just contact me if you've got any issues. So I have been about hearing more and more, I think Isabel knows what I'm talking about, but more and more people are saying they can't get appointments, and now they're ignoring my emails. But the wider, really important, critical point, but about GP practice being accountable. Does anyone have any other questions? Councillor Davis.
Thank you, Chair. Yes, your presentation was very interesting, Rachel. My concern is that I've had a lot of concerned residents in my wards because of that problem. They can't get appointments. At the moment, from September, we have got 12,000 patients registered between our two practices. The problem is that puts us in an upper tier already. We are also in the middle of building another 1,340 odd houses, which means that and conservative estimate is we're going to have 4,000 extra patients. And everybody's wondering how we're going to cope with that.
I mean, it might be worth a conversation after this just to understand your particular circumstances. But the number of houses, list sizes change all the time. But the GPs are allocated funding per patient. So as people register, they will receive extra funding, and then it's for them to then decide how they use that money to meet the patient's needs, whether that is another GP or whether that's nurses or different triage models or whatever they choose to do. So they will have the ability to do that. So the money should follow into the practices as people register their needs. But I appreciate your concern, and I think it would concern GPs as well. From, you know, they also are worried about being able to deliver the right level of care if they suddenly get a lot of new people in. So, but happy to talk about where exactly that is, if that's helpful. Yeah.
Thank you.
Can I ask, just, I'm not a curveball, but one thing that I always, and I've said this before, all the various aspects of the NHS, they do often come back to the fundamental problems in the NHS and needs for significant reform. And I was just doing a little bit of number crunching earlier, you can't get round, I know this is a national issue, but I'd just be interested in your response. The NHS costs £200 billion a year, and income tax is 300 billion. So 2/3 of everyone's income tax, everyone works and pays the tax, goes in the NHS. It's just mind-boggling figures. The public perception and experience, there are examples of phenomenal service, but the day-to-day, the GPs compared to, I've got family in America, and they just couldn't believe it when they spoke to my mum, and she said, I've got something and I can't get an appointment. What? I just don't get that. I've just got an appointment. My daughter's got a problem with her ear, and they said they can see within an hour. It's just so many problems with the NHS, so much cost, a reluctance to address the real issues and the need for significant reform. People who work in the NHS who are obviously in a good position to suggest things probably feel that they can't. Being an NHS whistleblower or complainant is not a fun place to be. So just on the whole issue of the fund, if you've got any just thoughts or ideas around the whole issue of fundamental issues and costs of the service.
It could be a whole new presentation. No, you raise a good point, and I think that's what the 10-year plan is really trying to address with bringing care closer to home, neighbourhoods, moving services out of hospitals into communities, making it more accessible so that people can access healthcare when they need to. But it does take a huge amount of reform to do that, and it's a big change from how clinicians work, how patients see it. So it is going to take some time, but I think that's what they are trying to do, as well as trying to be more of a health service as opposed to an illness service. And sometimes we get so focused on managing the illness that we move away from actually how can we keep people healthier, provide better support for them in the community so that they don't become sick in the first place. But it's not sustainable to go forward, and I think that message is coming through everybody in the NHS. I think people recognise it does need to change, and I hope that maybe with neighbourhood health, a different focus on that, going forward we might get to a better place where we're not as reliant on the hospital to provide the answer. I think, they're looking at modernising outpatients. Is that sometimes duplication? Do people need to go to an outpatient appointment? Could they make a decision for themselves whether they needed that outpatient appointment, and could we use that time for that surgeon, that doctor in a different way? So I think we could transform it on many levels. It is probably a whole different presentation, but I absolutely understand what you're saying, and it is very much something that we talk about all the time, is how we can best use our money to the best good of our population, really.
We had the Gateshead joint scrutiny. We had a presentation on the 10-year plan, and there was some good stuff in it, but it did very much seem like an improvement plan, not a plan for, didn't seem radical enough or accepting the fundamental reforms. It was some, I say some good, but it felt like an improvement exercise. From a business or an organisation, it was generally doing very well, but areas of improvement. But to be continued. And the next item is Jill, overview of public health services. Jill is our Director of Public Health, and she'll give an overview of the service and highlighting priorities for this year.
Thank you, Chair. Good afternoon, everyone. Delighted to be here. So, yeah, I am Jill. I'm one of the 5 executive directors here in the County Council, and I've got the statutory responsibility for being the Director of Public Health. It is a seamless segue, having worked 14 years in the NHS when public health was there, and then in 2013 we transferred across to local government, where I've worked for the last 11 years. So, whilst I am employed by the County Council, the Director of Public Health role is very much a systems leadership role, advocating for the health and well-being of the population. So forgive those who are very familiar with public health and have worked with us before, but the ask was around making sure everyone has a shared understanding of how public health sits in and across into the NHS as well as the wider system. And this is a standard statement that is from the World Health Organization. When we talk about public health, that tends to always sound like a function or a service. And actually, I like to flip it and say it's about the public's health. And where the NHS tends to focus on individuals, we focus on population level changes and ultimately how we can prevent disease, prolong life and promote health through the organised efforts of society. And a common theme that will come out of my presentation is we don't like doing anything by ourselves, basically. In public health, we have to work with and through everyone to achieve these shared common goals and purposes. And the other bit that you'll hopefully come to the end of this presentation and have a better understanding of is that everyone in public perception, I know, Chair, you mentioned about public perception before and how incredibly important it is for us. The public's perception is that the NHS will cure and solve all ill health and keep us healthy. 20% of health outcomes are attributable to healthcare. Only 20%, and the rest is what we might refer to, and you'll hear it in different language, wider determinants, social determinants, or more recently we've started to talk about it in quite simple language of the building blocks for a good life. And that's why the right and proper place for public health is in the local government, because this is about our education systems, looking at how we can ensure we've got the right skills, good and fair work and employment opportunities, transport networks, and actually housing is fundamental. And 20% as well of health outcomes are attributable to good homes. And then 35% is about material deprivation, poverty, income, good jobs. So when we talk about the public's health and our services, this is more about how we influence the wider system to understand we've all got a role to play in ensuring that the health and well-being of our population is as good as it can be. We are ultimately interested in closing the gap in equity and access to opportunity. And again, as a bit of a leveller for everyone as we progress into the term of overview and scrutiny, there's 2 key measures that we will always refer to that are fundamental for us. It's healthy life expectancy and life expectancy. And the top one for me is the most important in many ways, because that's about adding quality of life to our years and not just having longer years to live. This is all about how we live as well as we possibly can. So they're our biggest trajectories that we always look towards. So whilst our longer term ambitions are around closing these gaps, it's what are the shorter term outputs that we can put in place that we will know have a part to play in achieving these goals. And when I talk about inequalities, we tend to a lot focus on Northumberland compared to our other northeast neighbours or compared to England. But actually the team that are working in Northumberland is actually most interested in the within county inequalities that we have in relation to our health and well-being outcomes. And you can see right from the start in life that those areas with the least deprived wards, you've got free school meals of about 2% of our population, through to in some of our most deprived wards, you've got 52% of children will be on free school meals. That is within the county. And then that tracks through, I won't go through them all, but ultimately when I talk about healthy life expectancy and the fact that these outcomes are preventable and avoidable if we have the right infrastructure in place, the right policies in place and the right services in place, we've currently got a 16-year gap in healthy life expectancy just within the county. And that is something that's certainly our mission and our ambition to work collaboratively with all of our key partners to address. But that won't happen quickly. It doesn't happen in the next 2 years. And we very much talk in the public's health way of working. It's beyond political cycles. This has to be a shared ambition for at least 10, 15, 20 years for us to start to close these gaps. And it's about how we can come to that common understanding of looking at how we have those shared goals, irrelevant of political party, if I could be so bold, because this is about the common purpose and we all want our residents to live a safe, well life in Northumberland. So my role from a statutory perspective through the Health and Social Care Act is that I'm categorised as the Chief Health Advisor for the local authority and for indeed the system. If you were around during the pandemic years, it was Liz Morgan before me who set the advice and guidance and tone of direction of travel for Northumberland. And as Directors of Public Health, we also have direct access and link to Professor Chris Whitty, who is our Chief Medical Officer. So that's the direct line from a national perspective where we get our advice and guidance. But the three key components are around health improvement, health protection, which is where the likes of the pandemics would come in, and also the health care, public health work. So when Rachel was referring to the NHS, looking at moving from treatment to prevention, then a lot of that advice and guidance comes from the public health teams at a local level, and also started to employ public health qualified staff into ICB and into NHS structures as well. So we straddle that system. We've come with a number of key responsibilities that are mandated from legislation, and there is a public health grant that's got a set national formula that looks at levels of deprivation and health outcomes that enables us to get a set allocation. In Northumberland, our last grant was approximately £18 million. That sounds like a huge amount. When you think about our population size of over 320,000 people and the inequality divide that I just mentioned earlier, that isn't a huge amount of money to disperse for the scale of issues that we have, but we've also had some huge successes. Majority of the public health grant is spent on commissioned functions that are listed down the left-hand side there. So we are required to deliver the drug and alcohol services that we have in Northumberland, the stop smoking services that we have, as well as having a public health team that's qualified to give appropriate system advice and guidance into the NHS and into wider parts of the local authority as well. I mentioned before that we don't do anything in isolation, and that is because we absolutely have to work with all key partners, both internally within the council, but externally as well. So myself and the team are seamless, and hopefully Neil would agree, we work into and alongside adult social care, looking at how we can support their prevention model, work very closely into children's services, looking at how we can ensure our children are born and grow and thrive and are well, into a huge amount of Simon Nielsen's remit, looking at planning and housing and economic regeneration and transport. And so I know certainly Councillor Green, you're on the Health and Wellbeing Board. So we do have, it's on the website if you're not familiar with it, which is our System Partnership Plan, which is our joint strategic plan and needs assessment. That is another statutory requirement that we have this. And in the 10-year plan, the Health and Wellbeing Boards are referenced as continuing, which is a positive for us as a collective system, because we've got a very mature Health and Wellbeing Board in Northumberland with active participation. We then have various local forums to drive certain priority areas, such as Tobacco Alliance, and we have a Health Protection Assurance Board, and we're in the process currently of updating our pandemic plans to make sure we are fit for purpose into the future. When we talk about inequality, people will tend to focus a lot on poverty, and absolutely rightly so. As I said before, 35% of health outcomes are attributable to material deprivation. But for us in Northumberland, in our makeup and our geography, we tend to focus on the 4 domains of inequality as an absolute priority for us, just to think broader than beyond socioeconomic status in relation to disparities and potential disadvantage. So geography and rurality and equity in access to opportunities is fundamental for us. So we never look at anything that we're doing from a homogenous, universal perspective. We always need to make sure, well, how would this land in Wooler? How would this land in Bellingham? As well as how might this land across and into went off there, that mic. Protected characteristics. We've got an ageing population in Northumberland, so age is a particular priority for us to consider. How do we ensure our population is ageing as well as possible and can thrive and be independent in their own communities and homes as long as possible, as well as the likes of then moving into our inclusion groups, which perhaps is less of a familiar term for you. So these aren't protected under the Equality Act, but this population can experience inequity in access to opportunities, such as carers, for example, because they have that much more going on in their lives. The likes of going for vaccinations or screening appointments means that they are perhaps more disadvantaged and less able to come forward, have more barriers in their life. So we look at inequality in relation to what barriers are there in people's lives and how can we look to overcome them to enable people to have a sense of autonomy and agency to look after their own health and well-being. There is a team that sits under myself, and because of my wider executive portfolio, I've got 2 deputy directors of public health. So that's Jim and Luke, who will probably become familiar faces coming into this board, depending on the forward plan. Consultants in public health is our qualification, and just as an assurance, we are categorised as a medical specialty, but we are multidisciplinary in our nature. But if you are familiar with a consultant paediatrician or a consultant geriatrician, well, a consultant in public health, we undertake a 5-year specialty training programme, but it's about the population's health as opposed to a specific disease condition or a specific part of the population. So Jim and Luke are both qualified consultants in public health and lead the directorate function for me. Tammy Smith is in training to become a consultant in public health. And we also have registrars. Pfizer's here today, so Pfizer's within her 5-year training programme to become a consultant in public health. And then sitting below that, again, this is more for your thoughts and consideration for forward plan ideas and areas that you may be interested in, scrutiny and challenge. But we have divided the team into 3 overarching areas: living and ageing well, public health policy, place and intelligence, and starting and growing up well in public mental health. We've got service plans that obviously our lead member, Eve, is fully cited on. And I'm just going to spend literally a couple of minutes just highlighting the wealth of work that is undertaken by the team. So and I've got 1 slide on some stats for you, but we've had 15 plus years of work in relation to tackling tobacco and smoking. We do have a huge success in Northumberland in relation to our prevalence, but it isn't only about offering a stop smoking service. This is about tackling industry tactics in relation to encouraging people to become addicted to nicotine, and also the illicit tobacco trade that we see in place as well, which is criminal activity, and the most recent vaping bill that the public health community nationally was part of advice and guidance and working towards. I mentioned before about the drug and alcohol services that we commission across the county, but ultimately from a preventative perspective, we are just launching our new alcohol strategy that's coming into Health and Wellbeing Board in October, which is about how we can look at harm reduction, harm minimisation, messaging around alcohol. And then the local health protection arrangements, if we were to get an outbreak of a certain disease, whether that be salmonella, we work very closely with environmental health colleagues and UK Health Security Agency. So that's Jim Brown's portfolio areas and the team that sits with him. Moving to Luke's portfolio area, this is we do a huge amount of work with data and intelligence, and Rachel, you made reference to that. We need to understand the data to be able to target our commissions and target our work. So there is the Joint Strategic Needs and Assets Assessment, and there's a data hub. If any of you came along to the members' induction session, then Pam Forster was there showing the data hub and the amount of available information at ward level for you to understand your health profiles at a local level, and then that is all there, and we can resend those links out for members. So please do go on, have a play, understand that local health dynamic through the data that is available for you. And then Luke's team, as I say, focuses on the building blocks for a good life. So we've done a huge amount of work with housing colleagues and our regeneration colleagues, and also community assets and development, and we are the lead commissioner for the voluntary sector for the County Council. And then the third portfolio, led by Tammy Smith, is Starting and Growing Up Well, and our public mental health portfolio. Our main provider for the 0 to 19 service, or you might be familiar with it being called health visiting and school nursing, is delivered through Harrogate and District Foundation Trust. To reassure you, all staff are local and work locally. It's not that they're based out in Harrogate or anything like that. They're all co-located in our family hubs, and we've got incredibly strong relationships with our children's services and the 0 to 19 team there. An area of priority for us is to do more around our mental health work and our public mental health work. We don't commission the treatment services of mental health. We focus on promoting and protecting the mental health of our population and looking at the likes of resilience and ensuring people can live with good mental health, whether they have a diagnosis or not. One outcome and performance data slide, just to set the tone and hopefully whet the appetite for you to go on and have a look at some of the local data. But as I say, our smoking prevalence in adults is now down to 8.2% of the population are still smokers. And when you drill down into that, it is more likely to be people who've got complex lives, people who've got severe and enduring mental ill health, and also people who are in a manual roles. So we know who our population is, who are still smoking, and we're working closely as we can to understand how we can support people to come off nicotine as an addiction. And do the wider tobacco control work. Not going to go through all of them, but just to pick up on the MMR vaccination point there, we've got a 96% uptake of MMR to have herd immunity. So for the population to be as safe as possible, you need 95%. So Northumberland is overachieving on that. But clearly we don't sit in an isolated bubble, and people clearly transferring across into borders. So there is still more work to be done across the North East, in particular in pockets in Newcastle and Middlesbrough, Redcar, Cleveland as well have got lower uptakes. And the final one to highlight is our suicide rate, which is over a 3-year period per 100,000 population. We do have higher levels of death by suicide in Northumberland compared to England averages. We are on the cusp of launching a suicide audit to better understand this and developing our mental health strategy as well to do more to support people who are feeling that death by suicide is an option for them, and what more we can do in a preventative way. And again, working very much at system level with all of our key partners on that. There is more to be done in that area. And just a couple of highlights to finish off. You may be familiar with the fact that we have commissioned and are working closely with the Institute of Health Equity. You may have heard of Professor Sir Michael Marmot, who is our international lead in relation to epidemiology, which is the patterns of disease and understanding what those causes are to ill health and what we can do to prevent them. And the Institute of Health Equity has 8 key policy areas, but we over the last year now and into this year are doing 3 deep dive areas, one being on housing, which we've now got our published report finished and is going to be influencing our county-wide housing strategy. We've done a deep dive into employment, and we are bringing that into a Health and Wellbeing Board session next week in relation to the emerging recommendations, and we're just starting the deep dive work on Best Start in Life, which is how we can best support our 0 to 5 population, which inevitably means how do we support parents as well. So that's the Institute of Health Equity work. And finally, we, over the last 3 years, have had a real push for everyone to have a better understanding of inequalities, but without it being seeing it as a negative. So we flipped it, and we very much talk about the strengths and assets of Northumberland. You go into any community, in Cope and Key, in anywhere, and it's always about pride and dignity and what's strong in an area and what more we can do to build on that sense of community and say, well, what else can we ensure is available and have that equity and access to opportunity? When is it our responsibility at a civic or statutory level? When is it that the council or others can reach in and give a helping hand? But what is it, that sense of agency in communities that they can do for themselves? And that's a real critical push for us. That links us to one of our best transformation programs called Communities First, which is our council transformation towards all aspects of local authority work, taking into consideration prevention. When is it that is our role, but when is it that it might be better placed for the voluntary sector to do instead of us, or an NHS colleague to do, or when is it even that communities and volunteers can do? So we're spending a lot of time understanding our data and our communities to look at how we can ensure our voluntary sector is as fit for purpose as possible to be a strategic partner with us on this transformational shift towards prevention, which is very much aligned to the national direction of travel that Rachel referred to. So that was all I was going to cover as an introductory guide to public health. Thank you.
Thanks very much, Jill, and really appreciate all of it, but I appreciate you mentioning housing, because housing is just so central to mental health, financial, everything. So glad you emphasised that at the beginning. Just quickly, before I bring others in, I had a conversation with Councillor Jones and Councillor Chicken before the meeting about suicide, and there's been a lot of cases in Berwick, particularly young men, and I mean, I had somebody who's involved in education who said in recent years they know of about 17 in Berwick and the surrounding area, and people are obviously very upset about it. And I've done a little bit of work, first of all, to capture the data. And I think when you ask, and obviously we'll be having the coroner, the data, I suspect that coroners are, how can I put it, maybe a bit sensitive to families, how they record, even helpful for life insurance policies. So I don't think the coroners, all maybe a good reason, getting the data that we need, because when I look at the official figures, it doesn't hear with what I'm hearing. And I don't know if you'd, capture it in terms of suicide and misadventure. Could a coroner suspect a link with mental health? Because I don't think we are capturing the data. So the work you're doing, the suicide audit, would it be useful for you to do that and then come here? Do you know roughly how long that would take?
I haven't got exact timescales, but we are working with the Coroner's Office in relation to the suicide data, as you refer to. Yeah. But we can certainly look at the forward plan and bring that back in when it's got initial conclusions. There is something about the coroner's information that it doesn't always correlate year to year with the deaths that are actually occurring in the community, because if there is further investigation to be done, it might be that it tips into the next year where it's published in the coroner's report, but the death actually occurred the year before. So there can be some misalignment for procedural reasons as to why the deaths are established by the coroner at a different time to when they actually the actual calendar year when they occurred for the family. So that's one known difference or variation in the data sets. Yes, it can be whether or not if the coroner can't confirm fully about death by suicide, that it could be misadventure instead. But the coronial proceedings do look at that whole wider implications of mental health services being involved or not, and drug and alcohol services being involved or not, because sometimes that death by overdose can be, is it misadventure or is it death by suicide? So there can be a lot of nuances to individual circumstances. And I think that just the last bit in relation to into Berwick, or there's also there's been messages about farming community. I think the suicide is never just impacted by that individual family, is it? The ripple impact is really significant, whether that be a young person and therefore it's into the colleges, or whether it's into the workplace. So we're very mindful that it is a population impact when there is a death by suicide. We know from national evidence that there are unfortunately common themes do emerge, whether that be around loss of income, whether that be relationship breakdown. So there are, and it is unfortunately men under the age of 40 who are more likely to choose death by suicide as a mechanism for them. So be very keen to bring the suicide audit back and to have a further discussion.
And would we be able to, obviously looking at Northumberland as a whole, but would it be good to have some sort of comparable data to see what places are having more than, should is the awful word, but you know, that's a particular high number?
Yeah, so I know that ICB, we're undertaking a clinical audit at a reach, so we will have ICB level information that we can draw upon, and there is obviously national data sets as well for us to look at, so we can look at comparator. Could we put a call out, obviously respect people's, but anonymise them, we're not giving names, but I think there would be people prepared to come forward to say their experience of a loved one. I think, because there's a lot of people, understandably, people say, I want to start holding meetings, I want to say, people want to do something to help because they're so upset about it, and I think it'd be important to get information from the communities as well, how we'd actually manage that. So we've got a number of commissions between ICB and the local authority. So the likes of If You Care Share is one of our charities that we commission to support families. So it would be good, Chair, if we could maybe take it away and have a look at what we can and can't do. I'm just mindful of how emotive the topic is for people. Yeah. And listening to individual stories. And I think for me, to put strategy and policy in place, we do need to appreciate the individuals, but let's try and keep it at population level to avoid those sensitivities.
Yeah, great. Any question or anything to the report? Councillor Hunter, then.
Just really following on, because you brought up what I was going to bring up, and I think it's not just the person that's lost their life and their background, it's the whole family. Absolutely. Because it has increased in the north recently, and I think we need to look at it, because how that affects another member of the family might end up triggering onto something else. So I think that to come back at the appropriate time, I think would be a good idea.
And we do know actually that if people have experienced suicide, death by suicide in their life, whether that be family member or friend, it can increase people's consideration of it as an option, and therefore we are very mindful, as you say, of that ripple impact.
Councillor Green.
My question isn't suicide related, so are we still on that subject? Okay.
Something else, that's
fine. Hi, thank you then, Chair. When I came to the induction day, I was particularly excited by the presentation of the data that we can get. How can we access that as councillors, and how detailed does it go down to postcode or just the ward or streets? What information can we get?
It's all available on the website, so we'll resend out the links. So we've got the Northumberland Data Hub as well as the Joint Strategic Needs and Assets Assessment. Depending on the data collected, it will go down to ward level, but if it becomes too sensitive in relation to being identifiable, then it might not go down to ward level. So it just depends what particular indicators you're interested in.
Okay, thank you.
Councillor Carr.
Yeah, thank you, Jill, and well presented. And yeah, it is really saddening to see that the levels of suicide rates in Northumberland increasing. I'd be interested to know of the data presented, it was only for the last 3 years. Is that something that has always been increasing, or is that something that's been lower before? And I really do truly hope that the audit brings back some data to try and identify the reasons. I personally think that COVID lockdowns had a lot to do with it, as based on the 3-year data that you had. But I've always personally believed that, especially young people, as you said, young men over 40, and I think this includes girls as well, is that there's a lot of social media has a lot to do with it, peer pressure as well. Anything basically where a young person feels they have to compare themselves to a lot of their friends. Again, I hope these things can be tackled, and I hope that the audit does bring back some ways that we can look as to how we can do more in Northumberland and England as well as a whole. So yeah, thank you for that, and I hope it goes well.
No, thank you, Councillor Carr. And it's deliberately 3-year pool data, because whilst every single death by suicide is abhorrent and incredibly sad, the numbers are relatively small, so we pool the data to be able to understand the trends in a bit more detail. So when we do the audit, we will go back beyond the current 3 years that I'm sharing with you. And there is a huge amount of evidence already about thematic reasons as to why people go through this process, but we'll be able to compare that to what we understand at a local level. So there'll be a qualitative narrative alongside the numbers in the suicide audit that we'll produce.
Thank you, Chair.
Thank you. Councillor Chicken, did I see your hand up? No, you didn't. Councillor Smith, and then.
Thank you, Jill. I'm just thinking about the impact, as you said, about alcohol abuse within the general population. Over recent decades, we've seen a significant change in the demographics, and I think Northumberland was traditionally blue-collar, heavy manual industry, and was part of the traditional culture that men went out to drink Friday, Saturday, how you be down the next. Now they've moved away more to a service-based industry, and we're seeing women coming into the workforce in increasingly educated roles. Are you seeing any changes in the demographics in that respect?
Absolutely, yes. It's John Liddell, who's been leading on the development of the alcohol strategies, done a lot of qualitative work alongside the data analysis. What we're seeing is actually in our younger population, our teenagers are drinking less, and it is actually our middle-aged to older population that are the heavier drinkers. We did see a spike during COVID over that period of time, and we've seen the increase in the likes of liver disease coming out of COVID because of that drinking at home culture. So yes, we are seeing more women come forward into our treatment services now, which is great that people are coming forward, because there has historically been quite a lot of stigma attached to coming into treatment services. So we're deliberately uncoupling drugs and alcohol, because they're very different cohorts, they're very different activities, and they've got very different health outcomes as well. So it is very much across all social gradients, an increase in alcohol dependency and dependent drinking. But we're also trying to do a lot more in our nuancing of campaigns into workplaces about how to be aware of how much alcohol people are consuming, because there is still lack of understanding of what units actually mean on the backs of bottles and such like. So we've got a lot more to do, and are continuing to work with alcohol industry as well.
Councillor Davidson.
Thank you. Thinking about COVID again, there seems to be a trend of fear in adult vaccinations because of side effects, and people have heard from different people that they've been ill and long COVID. Is this a worry to public health?
We know that the evidence that we have available to us at this point in time, that the vaccinations far outweigh some of the risks that individuals are receiving. I'm sure you can appreciate that with all treatments, when you read the patient leaflets, there's risks with any medication that you take, isn't there? And unfortunately, there will sometimes be that 1 in 100,000 people that does have a side effect, and we are likely to have heard about that 1 in 100,000 population or such like, for the hundreds of thousands and millions of people who are undertaking taken the vaccines and are perfectly safe and are therefore protected from the likes of COVID, then it's absolutely worth doing. So from a public health perspective, we are absolute advocates for vaccinations. Our role is to look at the misinformation that's out there, provide facts, figures in accessible formats so that people can make informed choices and understand the information that is there, because it is ultimately about informed choice as well. But yeah, from a public health perspective, the vaccinations that are highly regulated in this country are quality assured and as safe as they can be.
Thank you.
Did anyone else? Councillor Carr.
Just one more, Chair. The data on the smoking, did that include vapes? Because I know we see a lot of vape shops popping up around Northumberland, but I'm just interested on the health implications of vaping as well.
Yeah, so at the minute the data that we've got there is purely around tobacco smoking, but we are collecting more and more information in relation to vapes going forward as well, but the decline is in relation to tobacco.
Councillor Green.
Hi, thank you, Chair. Going back to the 8 building blocks to improve people's life expectancy, are we doing anything to address any particular one of the blocks? Can we throw money at transport, for example, or money so people could have more money? I don't know. What are we doing?
So the housing and health work has been a fantastic piece of work for us, where we've worked across private sector landlords, social housing providers as well, and indeed as a local authority we're a landlord of 8,500 properties. So we are looking at how our housing colleagues can take into consideration tenants' health and well-being, so that they can ensure that they are good, healthy tenants, therefore more likely to be in employment, therefore more likely to be able to pay their bills and stay in their accommodation. The other piece of work that we're doing with our housing colleagues is understanding people at risk of homelessness, which often comes with multiple complex needs, where, and how we can better work collectively to wrap around residents who are at risk of becoming homeless to enable them to stay in their own property. Again, we can share the link to the Institute of Health Equity Housing and Health report that is now published, that is highlighting the number of recommendations that we're now going to be working towards on the county strategy. So that's just one example.
Okay, thank you.
Councillor Chicken.
Thank you. Just to sort of clarify, when we're looking at data for smoking cigarettes and smoking vaping is looked at differently, but we are looking into that because, generally speaking, people who are smoking are advised to go on to vaping as a way of cutting down. Nobody's advised to go on to vaping without having smoked beforehand. Some people do choose to do that. I don't honestly know why, but they do. But we are looking at both of those separately. We simply don't have enough data yet about vaping because it has not been out there long enough. We know loads about cigarette smoking, and the amount of work that has been put into reducing cigarette smoking has been really, really effective in Northumberland. We're now down to only 6% of Northumberland's population actually smoking cigarettes, adult population that is. We do also look at teenagers who smoke and vape. Smoking in teenagers is very, very low, but vaping is unfortunately higher than we would want it to be. But we do look at it, we look at it separately, and we look at it in ways that we can manage that and approach that. And like I say, it has seemingly been very effective in order to bring that population down to just 6%. Is really effective. So we are working on that. Thank you.
Anyone else on this? Okay. The next, the final items that are important items, which form the work programme, I'll pass over to yourself for the forward plan, page 1722.
Yeah, so it's just to note the forward plan, so that just outlines what's going to Cabinet and what has recently been decided by Cabinet. And for the work programme, I don't have any updates other than what's in the document, but I have made a note of a number of issues that have been raised in today's meeting, and I'll work to get those on the programme in the future.
I don't think there's anything in the forward plan that's particularly pertinent to us in the Cabinet.
Yeah.
Is there any I mean, this is an ongoing, so just email at any time you think of anything. But is anything else you'd like to input into the work programme at this stage? Councillor Trick?
Yes, thank you. At some point, when we can look at it, I'd like to put a little bit of focus on occupational-related mental health, particularly because we are such a rural county. I would like to look at what mental health is affected with people who work within the rural communities, so that is the farming, not just farmers themselves, but those sort of within and around that sector, and what the physical and mental health impacts that has. Secondly, we are the biggest recruitment ground for the armed forces in the North East. We know that the armed forces, particularly the veterans and also those who are serving, often suffer greatly with mental health, and that doesn't just affect them, that affects everybody around them, and quite a bit of that actually comes from their physical health. Once they come out of the army, a lot of them who are medically discharged, their lack of physicality then affects their mental health, and it's the same for emergency service users, so that's the fire brigade, the police and the ambulance service. If at some point we could look further into those details in whichever way you see fit, I would be very grateful for that. Thank you.
Jill?
So we are going to be developing our mental health strategy, and we are going to be looking at specialised cohorts, of which veterans and farming have already been identified. So it's probably worth looking at before the strategy framework is set, coming in here earlier to ensure that scrutiny are satisfied with its direction of travel, and then coming back again through its consultation journey. Would that work?
You happy? Yeah, I'm happy with that. You're happy with that? Okay. Yeah. Great. Perfect. Anything else, Councillor Hunter? Yeah.
What we usually have an update on preparedness for winter. I think if we could have something like that, and at an appropriate time, an update on the Berwick Hospital, because it should be opening shortly. So, and it's what services it's going to provide, and that.
Is that not all?
It's on November.
November. It's on November. Yes. And there's a little bit of a concern recently, wasn't there, about merit? There's a wind-up petition for the company doing, but I'm not an accountant, right? But I do get the feeling that that's not going to affect finishing off a project, which is 4 months to go. You haven't heard that? No, I think it was just yesterday, wasn't it? Just yesterday it came out that Merit the tax office were doing a winding-up petition. I was hoping you'd say we can give definite reassurance that it's not going to affect the hospital. You're just looking at me like, really? What? It may be quite good if somebody could put a statement out, actually, about the hospital. Would they, yeah, give them a prompt. Anything else on the work programme? Let's see, have a think, and any time email myself or Rebecca, and we'll look to get that on as well. Urgent business, I haven't been notified of any. No, and the date of the next meeting is the 4th of November at 1 o'clock, usual time. Thank you very much. I think it's been a really useful meeting. So thanks for everyone for attending and contributing. And thanks for your presentations.